Okay, so the title I'll talk today is the TissueGene C, a potential therapeutic for treating degenerative joint diseases. When we talk about the degenerative joint disease, we talk about specifically in the knee osteoarthritis, and you all know that in osteoarthritis field, initially you start with the some minor arthritis with lower KO grade, and then it continue to progress to become more severe, and at the end gonna be bone to bone together. That causes a lot of pain. But when for the treatment of this type of osteoarthritis, typically the doctor probably provide you with some sort of painkiller, such as NSAID, and then followed by potentially steroid shot. And then, however, in between, the initial early osteoarthritis and at the end state, which is bone to bone, that the only thing you have left, basically, when you hit that state, you have basically come up back with a knee replacement. And that will be a costly surgery along with a long rehab. So there's absolutely a need for some sort of therapeutic to actually target for the knee when it starts to become more severe from KO grade 2 to 3, which is between these two. So what we think is that our company developed this drug. This is a cell and gene therapy product that designed specifically to treat osteoarthritis. And let me give you a little bit background information of this particular product. It is a cell therapy product that composed of two different cellular components. The first one will be a chondrocyte component that isolated from the human donor cartilage. And then from there, we prepare our drugs substance from there. And the second one will be a cell line that actually, human cell line that have been transduced to express the TGF beta. And this is a clonal cell line that also will be irradiated at the dose of radiation to make sure the cell replication incompetent would not survive long in the bodies. And for this, for the mechanism of this particular drug, we now want to give you a little bit background about the osteoarthritis. In the left side of this cartoon, you see that when you have some sort of injury, then we're going to have some sort of upregulation of some of the inflammatory cytokine, and that's actually causing a lot of issues such as inflammation. And then these inflammatory cytokine actually cause upregulation of some of the matrix degradation enzyme, which actually cause degradation of your cartilage and basically destroy your cartilage. In addition to that, these cytokine and immune cell that activating by these cytokine actually generate more inflammatory cytokine, and so you have an amplification of this inflammation in the knee. And then the last thing is that these cytokine, inflammatory cytokine will activate some of the pain signal and cause significant pain as well. So what we think is that when we have our drug, this particular drug, inject into this osteoarthritis knee, so one of the components of our drug is the cell line expression TGF beta. The TGF beta component will actually recruiting immune cell and then differentiate the immune cell into an M2 macrophage or anti-inflammatory macrophage, which produces anti-inflammatory cytokines such as IL-10. Then from there, basically, it's reducing the inflammation in the knee. In addition to that, we think that the TGF beta sort actually provide some signal to the resident chondrocyte to start to regenerate when you reducing the inflammation. In addition to the TGF beta component, we know that other bioactive factors that derive from our drug actually have some other additional inflammatory activity as well. So we will present you some data around this. So what we think when we inject our drug into this OA knee, we basically slow down the inflammation, allow the resident cell to actually regenerate and help with the pain. Okay. Next. So I'm going to take you back a little bit into in vitro work to look at what we want to learn is about the mechanism of action, how the drugs have this anti-inflammatory activity. So we actually using the in vitro model of macrophage and looking at what is in our drug that actually can induce this anti-inflammatory activity besides TGF-beta that we know of. So when we test out basically drug supernatant, what we've seen is that this in the blue bar, we have now drug actually induce a anti-inflammatory IL-10 activity as detected by ELISA here. It's similar level like the control, which is the IL-4 and IL-13. And in addition to that, we also look at the inhibition of the TNF alpha. And then very similarly, our TGC drug actually inhibiting the TGF-beta that induced by LPS, which is one of the basically component that used to induce inflammation in this cell culture model. And in addition, we also look at the another M2 anti-inflammatory cytokine we call IL-1RA. And similarly, we do see that the TGC drug can induce this M2 cytokine. So the take-home message from this is that we know that both of the in this study we show that both our drug TGC along with the chondrocyte component have the anti-inflammatory activity. And I wanted just to remind you that in this particular experiment we performed the study in the presence of serum, and we know the serum have a lot of TGF-beta. So due to the interest of time, I'm going to shortcut this a little bit. I'm going to skip through this next slide and go to the next. Sorry. So since we know that there's a TGF-beta present in fetal serum, so we actually test our same model, but in the absence of this FBS. So what we see that in this cell macrophage model, we see the TGC, which is shown blue, have the it can induce IL-10, whereas the chondrocyte component alone, we show in orange, have some activity, but not to the same level. However, when we incubate the chondrocyte component of our drug together with purified TGF-beta, we have a similar level. So we know that this particular anti-inflammatory activity in our drug actually induced by TGF-beta and actually probably derived from the chondrocyte component. And basically, when we look at the TNF alpha, very similar, both TGC or the chondrocyte component together with the TGF-beta can inhibiting the TNF alpha, which is the inflammation cytokine. So we try to further identify which is exactly the molecule that are responsible for this activity. We went through cytokine array, try to find some of the protein or cytokine that have the anti-inflammatory activity. Unfortunately, we didn't find anything. So we actually go through with hypothesized could be a low molecular weight material. So we went through fractionation and then look at the low molecular weight and go through the proteomic analysis. And one of the component, one of the bioactive molecule that have been were identified in our screening, together with some literature search, we actually tested. One of these is called prostaglandin E2. What we found is that we found that these PGE2 actually expressed or produced by the chondrocyte component. And when we treat our chondrocyte together with the TGF-beta, shown in the red bar, we see significant upregulation of production of PGE2 and very similar level with the TGC as you show in the blue bar. So our results show that basically the PGE2 is one of the bioactive components that produced by our drug product that have anti-inflammatory activity. Now based on this data, we know that now we have identified this molecule that's responsible for the anti-inflammatory activity. we next to test this anti-inflammation in vivo. And when we look at in the rat model, when we inject either it's an individual component of our drug or together, the drug product, final drug product on TGC together, and look at the synovium after 4 days after cell injection, and to look for these M1 and M2 marker, which is the ARG1 for the M2 marker, and the CD86, which is the marker for M1, inflammatory M1 macrophage. So we see that in the TGC animal group, we show a high expression of the M2 marker, but not so much with the M1 marker. So our result again demonstrate that the TGC actually induced the expression of M2 macrophage in vivo, and which is consistent with our data from in vitro data. Is next we actually went through all the non-clinical study, and then basically we goes through human study. I'm going to skip this. This is the other animal studies since the time limit, so I'm going to skip this. We actually perform human trial, and I'm going to skip even phase 1, but go straight to the phase 2 design. This is the human trial. We look at the safety and efficacy of our drug into patient with KL grade 3 for the degenerative joint disease of the knee. And basically, it's a small trial with randomized, placebo-controlled, double-blind, and basically, with the primary endpoint is a knee functional and vascular. And this is some of the criteria. Sorry, and for this study. And let me show you what our result from our phase 2 trial. So we look at the knee functional on the left side through this IKDC score. What we see that within the human group, when you treat them with our drugs, TGC drugs show in the red trace, after roughly a month, we do start see the knee improvement, and this continue to be improved after 3 months, and the level of the knee functional improvement basically maintained up to 2 years. In the when we look at the pain response for our from the group TGC group that been treated with our drug, what we see again after 1 month, you start see some of the pain improvement, and this continue to improve up to 3 months, and then maintain up to 2 years. And it is statistical significant improvement in for the group that treated with our drug as compared to the placebo control. So currently we have finished up the phase 3 study in the US, and basically the dosing have been complete, and currently we're waiting for our result, which will be next year. In summary, for this part of my talk, basically we have demonstrated that TGC can stimulate the anti-inflammatory environment, and that leading to the pain and functional improvement in our rat model. The anti-inflammatory activity of our drug is resulting from the stimulation of M2 macrophage recruitment and polarization to basically reduce inflammation. And we also identify this molecule, which is a prostaglandin E2, is the main bioactive factor that responsible for our anti-inflammatory activity. In human, we have shown that both phase 1 and 2 TGC provides significant pain and functional improvement for the knee application. And then so far we have no safety concern for this previous phase 1 and 2 study, and in the long-term follow-up study as well. So as I mentioned, we are currently in phase 3, the finished dosing, and we're still waiting for our data. Next, I want to switch gear and talk about another different application using this TGC drug for degenerative disc disease, or DDD. So what we know about the degenerative disc disease, we should talk about lower back pain, which is one of the #1 cause in globally, and basically in our lifetime, roughly about 70% of our adults will experience some sort of lower back pain. And when you talk about lower back pain, usually it strongly associated with degenerative disc disease, and the discogenic back pain actually implicated in this roughly about 30% of chronic lower back pain patient. So, and typically you see probably 1 or 2 more discs in the human spine actually get degraded. That's considered to be degenerative disc disease. And the cause of this degenerative disc disease could be from multiple factors, non-genetic, such as aging, obesity, and maybe strenuous physical work, or smoking, and also certain injury. And what happened when you have this degenerative disc disease? Typically, you lost the proteoglycan component in the nuclear pulposus, which is the center of the disc. And then the lost biochemical property of this of the disc, and then the disc become dry out and become more brittle. So, and the result from this is that you're going to have a tear of the disc, that's the worst scenario. And then the spine will become less stable, and you have osteophyte formation. Sorry. And we get nerves compressed, which cause a lot of pain. And of course, there's a lot of inflammation. So typical treatment for this particular disease is simple medication, is painkiller to release the pain, and less swelling through like NSAID, and then followed probably by steroid injection or narcotic drug. And then, come on. So, and remember that the steroid will be a stronger injection that, but unfortunately, it will help ease the pain and swelling along with inflammation, but it actually, you only allowed to basically have 2 shots only. And then after that, the doctor will recommend physical therapy to help with the basically with the muscle to strain the spine, and also potentially chiropractic manipulation to bring the blood flow into the area. And at the end, basically surgery, which is one of the worst scenario. So to help with taking the pressure off, so we know there's an unmet need for treating the DDD disease. So why do we think our drug, TissueGene C drug, can have potential candidate for the drug for DDD treatment? And the reason, as I mentioned, the cell line have 2 components, which is chondrocyte, and then the other cell line, the expression TGF beta. And what we think, we already demonstrate that in the knee application, the TGC can release the pain, and then via the anti-inflammation, and also have some structural improvement. So what we think is that the chondrocyte component of our drug can provide the type 2 collagen along with proteoglycan for the nuclear pulposus regeneration. TGF beta sort from our drug can actually help to induce a synthesis of type 2 collagen along with proteoglycan for the resident chondrocyte in the NP, and also potential the chondrocyte component of our drug. And now we also know that our drug can release the pain and have the anti-inflammation activity, and it also have structural improvement. So in collaboration with the Korean University, we look at the DDD animal model using 2 different methods. The first one is chemical injection directly into the disc. And this on the second model is the puncture and basically aspirate the disc content from the nuclear pulposus. And then after that, once we generate the model, then we inject with our drug into different locations, L45 and L56 location. And then from there, we look at pain assessment through the voluntary filament testing and dynamic weight load testing. And here's the preliminary result, what we show is that in the chemical injection, look at dynamic weight loading. So after the chemical injection, after 2 weeks, you start see the pain sensitivity. Look at the weight distribution, and it show in this drop of this of the curve in black and then from there after 2 weeks. After 1 week after either cell injection, TGC injection, or vehicle injection, you can see the improvement 1 week after injection is shown in the red trace, and the improvement is continue up to 4 weeks. Now we look at another method, which is the dynamic Von Frey testing from a left and a right leg. And again, after 2 weeks, you see the animal have become more sensitive to the stimulation of Von Frey testing. And 1 week after cell injection is shown in the red trace, we start see the improvement of pain response, and this continue to improve almost up to the normal level, which is shown in the open trace. In the second model, which is the puncture model, we see reproducible result in dynamic weight loading and in the Von Frey testing. So our result indicate that animal inject with our drug, basically our drug can demonstrate to provide significant pain behavior improvement starting after 1 week.
We do need to move on to the next speakers.
So let me wrap it up. Okay. Let me skip this and I'll go straight to the final. So in summary, basically, that's good. It's actually almost the last slide. So we show that treating the animal DD model with our drug, we see the dose-dependent effect of response to pain improvement, and the TCG treated group significantly reduced lower back pain behavior after 1 week and continue to improve after 4 weeks. Currently, we are ready to start phase 1 study. Thank you for your attention.